osteology from the lateral skull view, and it is a small in size, it contains neurovascular structure that we will show in a while. This diagram will show you the boundaries of the pterygopalatine fossa from the lateral view. You can see it's bounded anteriorly by the posterior wall of the maxillary sinus, purple in color, posteriorly and superiorly by the by the pterygoid process, and medially by the palatine bone, as we will see in more details. So, in order to understand the anatomy of the pterygopalatine fossa, osteology is very important. So we will go with a few slides about the osteology of the pterygopalatine fossa. This is frontal view of the pterygopalatine fossa. As we can see, we are on the left side. This is the superior orbital fissure. This is the sphenoid sinus, both pterygoids, lateral and medial, and the greater wing of sphenoid. What we can see, the pterygopalatine fossa is in this place, so occupying this space, and we will talk about the foramens and fissures in a while. And when we bring the palatine bone and cover part of the sphenopalatine fossa, it will show that the most of the content of sphenopalatine is hidden behind this palatine bone, and most of the content is in this quadrant. Okay, we will follow the way of assembling the bones of the area. So this is the pterygoid, the sphenoid bone, as you can see, bilateral sphenoid, bilateral pterygoid, and this is the area we will target. This is the sphenopalatine fossa, and this is separately the palatine bone. We can see the horizontal portion of the palatine bone. This is the perpendicular plate of the palatine bone, and superiorly it will branch into two parts. This is the orbital process, and this is the sphenoid process. In between, we will see the sphenopalatine notch, where the content of the sphenopalatine will go medially. When we put this inside, assembling again, we will see this is the floor, this is the hard pellet, and this is the medial wall of the posterior part of the maxillary sinus. When you go up, you will find the two process, and in between, the content of the sphenopalatine will go medial. Let's come from the medial aspect. So we are looking at the area from medial aspect. This is, as we said, the palatine bone. This is the hard pellet, the posterior 1/3 of the palatine bone, the horizontal portion, and this is the perpendicular plate of palatine bone, and it is like what we said, branching the orbital process of palatine bone anteriorly. It's very hard bone. You need to remove it before reaching the sphenopalatine area, and this is the sphenoid process laterally, and this sphenopalatine the sphenoid process, it goes laterally and join the lateral process of the foramen bone to make the what's so-called palatovaginal canal, and we will see in a while. In between, we will have the sphenopalatine notch. As we said, the arteries and nerves comes out of this, and when we put this in this space, then you will see the area is covered. This is the area of sphenopalatine artery from medial view. This is the maxillary sinus. This is frontal process of maxilla. The orbit is expected to be here, and this is the sphenoid. This is the communication of the sphenopalatine fossa down to the oral cavity, and the communication to the orbit superiorly, as we will see in a while. This is another view. It's from lateral view, and as we can see, the whole unit all together. Before that, we can see the palatine bone in green, and this is the maxillary bone in green, and the yellow color is the palatine bone, and this is the notch we were talking about. This is the orbital process, and this is the sphenoid process of the palatine bone. When we bring the sphenoid bone over, it will make us the posterior wall of the sphenopalatine area, and the superior also portion of the sphenopalatine area. Finally, the up view. For us, it's less important. It's good for the neurosurgeon, but less important for us. But it will help us in understanding. This is the area of sphenopalatine, the palatine bone, the maxillary bone, and posteriorly the pterygoid bone. So this is roughly regarding the osteology and gross anatomy of the sphenopalatine area. Now we will come to the imaging. I'd like to show you some few images. I'm using this software. It's Xerix. It's very good software. It will help you in understanding the three dimensions of the any anatomical structure in the area, and we will target the sphenopalatine area. And now I will convert it into three orientation of the CT scan. So once I press over the area that I want to see, it will show in the coronal and axial plane. So we will come to the axial plane first. This is the sphenopalatine fossa, and this is the infratemporal fossa communicating by the maxillary sphenomaxillary fissure, palatal maxillary fissure. And when we go little up, we can see the maxillary nerve here going through the foramen rotundum. And when we go little bit down, we will see some few landmarks. Still the posterior wall of maxillary sinus, the infratemporal fossa. And when we go down a little bit, we will see this line that comes from posterior, from anterior to posterior, and from lateral, from medial to lateral. And this is median nerve and median canal, which goes to the carotid artery, to the foramen lacerum. It is one of the important landmark when you do this approach. When you go a little more down, you can start to see the pterygoid process, both medial and lateral, and you can see this small canal here, which represents the descending palatine artery. On the coronal plane, what we will see is the same almost. This is the sphenopalatine area. If you see something, one structure coming down, this one is the descending palatine artery going through the oral cavity. And if you go a little bit backward, what we can see on the contralateral side, please look at the contralateral side. This is median. Okay, this is the inferior orbital fissure, and this is superior orbital fissure. This is the median, and this canal, small canal, is the palatovaginal canal. There is an important arterial nerve going through this canal and going to the nasopharynx. When we follow the nerve, the median canal, it will guide us backward to the carotid artery and foramen lacerum here, which is very important landmark for the vitreous portion of the internal carotid artery. Look at the other structure, which is the V2, maxillary division of trigeminal nerve. If you follow, this is the V2. If you follow, it will guide you to the cavernous sinus because it lies in the lower border of the cavernous sinus. Here in the sagittal view, you can see the area. You can see the communication to the orbit superiorly and inferiorly to the oral cavity through the greater palatine canal, and posteriorly, this is the median nerve going backward. This is more explanation about the imaging. Maybe this is more clear regarding some of the landmarks. So we can see here the base of the pterygoid process, and we can see superior, to the process, medial and inferior is the median canal, and superior and lateral is the median, the V2 nerve. And we can see, if we go downward, the median relationship of the median and V2, it's anteriorly, they are close to each other. Once they go back, they are divergent. So the direction of the median is from medial to lateral, and the from below to above, while the V2, it will come from superior to inferior and from lateral to medial. You have to know these landmarks, especially when the pterygoid process is pneumatized. Then you will have both of them. There is a good identification for both of these structures. This is axial view. This is the foramen rotundum, and this is the median. And when we go down, we can see the palatine canal transversing the artery. So, what is the clinical importance of this pterygopalatine fossa? It's very, very important area, especially whenever we have a tumor or infection. It will spread to the skull base, different area of the head and neck through those foramens and fissures. So we have the foramen rotundum, the pterygoid canal or the median canal, palatovaginal canal, palatine canal, sphenopalatine foramen, pterygomaxillary fissure, and inferior orbital fissure. We will see some of these openings and fissures. This is the osteology of the sphenoid bone. As you can see at the top of the pterygoid process, you can see both canals, the median inferior, and V2 lateral and superior. The median nerve, as we know, it transmits the maxillary nerve and communicate the pterygopalatine fossa with what? With the middle cranial fossa. And this is the occipital view. You can see the carotid from the occipital view, the anterior cranial process, and the median is, the V2 coming through the foramen rotundum this way and going to the middle cranial fossa to meet the B1 and B3 and form the Gazanian ganglion. And pterygoid canal is the same, but it comes through the fibrocartilaginous structure at the level of the petrous portion of the carotid, which is the foramen lacerum, and it carries the median nerve and median artery as well. Some of the, or most of the cases, the median canal carries only the nerve, and the artery, in some cases, it's a separate canal. We need to understand these issues because whenever we have vascular region like juvenile angiofibroma, if you embolize, you need to embolize not only the external system, but also the internal carotid system through the median canal to control. Also, whenever you treat the juvenile angiofibroma, you need to cauterize and control this artery. Nothing can explain the importance of the pterygopalatine fossa better than this image. This is MRI of a patient with adenoid cystic carcinoma of the maxillary sinus involving the pterygopalatine fossa. And let us see how this tumor can spread in the head and neck. You can see the difference between pterygopalatine fossa here and on the contralateral side. So the fat plane is preserved and the vessels is preserved, while on the other side it is invaded by the tumor. And you can see the invasion extended through the pterygomaxillary fissure to involve the masticator space, and also through the B2, which goes anteriorly to the premaxillar area, involved in the premaxillary area, and also posteriorly and inferiorly to involve both pterygoid muscle here, and through the the palatovaginal canal, it extends to the nasopharynx in this view. On the other view, you can see the median here is involved, and B2 as well. We can see the clear involvement of the pterygopalatine fossa and the masticator space. Here you can see the extension to the orbit through what? Through the inferior orbital fissure. You can see involvement of the orbit and also the dural enhancement of the middle cranial fossa. So the area is very important area to understand because the extension of the tumor and infection can happen to the orbit and to different intracranial parties. What are the content of the pterygopalatine fossa? As we know, maxillary nerve, the artery, also maxillary artery, the median, pterygopalatine ganglion, and veins and lymphatic tissue. So now we will go to the endoscopic anatomy. So we got the gross anatomy, then the imaging anatomy, and now we will come to the endoscopic anatomy. As you can see, this is the posterior wall of frontal sinus, the maxillary sinus after removing the bone, and this is only the periosteum covering the content of the pterygopalatine fossa and the infratemporal fossa, and you can see most of the content are fat. The first structure that you face on the pterygopalatine fossa is the vascular structure, then the nerves comes after. And as you can see, this is the right side, this is the septum, this is the maxillary sinus, and this is, we removed the bony wall of the pterygopalatine fossa, and we can see the branching of the terminal branch of the maxillary artery coming out and down through the greater palatine artery. This is a short video. I'd like to thank my mentor, Professor Paolo Castelnuovo. We did a lot of efforts. He did actually for me regarding this understanding this area. So as we can see, this is the posterior wall of maxillary sinus. This is the branching of the sphenopalatine artery. This bone is the what we said earlier. What bone is this? Palatine, which part of palatine bone? The orbital process. It's hard bone. We are using here the chisel. We don't use it usually intra-op. We usually use drill, but for the cleaning of the specimen, we are using the chisel. So once you remove this part of bone, then you start to expose the pterygopalatine fossa. Here we go. The contents start to appear, the vascular and neural structure. First thing appears the arteries, the nerve and the ganglia becomes posterior to it. This is so many branches of the sphenopalatine artery. It will be discussed by, I think, Professor Casiano in a while. If we remove the posterior portion, we can see the median comes through from medial to lateral, and when we remove the posterior portion, just a few millimeters of the posterior wall, the medial wall, you can see the artery, and this is the artery. If you want to control the epistaxis, you need to clip it. In the fossa rather than in this area because it might branch before. This is the median, as we can see, and when we dissect, we can see the nerve, the ganglion. This is the ganglion, and again the median. When we remove the sphenoid process of the palatine bone and superiorly part of the sphenoid bone, we will go and see so many structure like V2. We remove the bone now. This is the V2, and this is part of the pterygoid. We can see. So this is the median nerve going to the carotid, to the petrous portion of the carotid. This is V3 through the foramen ovary, and this is V2 superiorly. When we bring it back, this is the sphenopalatine artery. This is the median nerve going to the carotid again, and here is the V2 going to the military fossa. This is another dissection, shows the relation of the median. This is the median after we cut, and this is V2. If you follow, this is V2 at the base of the cavernous sinus. If you incise here, you will see this nerve, which is abducent. Okay, abducent. This is the median again, and this is the foramen rotundum and V2 in this area. Up is the orbital apex and the optic nerve superiorly. Sure. 3 minutes. So surgical approach to the pterygoid area. Either we go transpterygoid, transmaxillary, or transpterygoid, transethmoid, transpterygoid, sphenoid approach. It depends on the area that you want to expose, whether you need to do medial maxillectomy or just posterior maxillary anthrostomy and reach to the area. And this is the branches of the sphenopalatine artery, and this is illustrate for you how the configuration comes out from the sphenopalatine. Median goes straight, the palatovaginal goes to the nasopharynx 45 degrees, and the septal branch of the sphenopalatine goes around the guana and comes anteriorly. So understanding these structures will help you during the dissection. And this is, as we said, it's just, pterygopalatine fossa approach. You need to just do maxillary anthrostomy and go to the area immediately. If you want to reach that far lateral to the infratumoral fossa, then you need to do Denker approach when you remove part of the anterior wall of the maxillary sinus endoscopically. What are the indications? So either we go trans-pterygoid approach to control the epistaxis or vegan neurorectomy, or just simple pathology in the area like schwannoma in this case, or in case of nasoseptal flap. What is the indication for trans-pterygoid, trans-ethmoid, trans-sphenoid approach for more extended disease like stemper canal, CSF leak, fetus apexis lesion, pituitary adenoma, craniopharyngioma, inverted papilloma, and juvenile angiofibroma. And this is just illustrated case of CSF leak and meningocele of the lateral sphenoid wall. We do maxillary, wide maxillary antrostomy and complete ethmoidectomy just to reach to the area, identify the sphenoid in this place. Then you do wide maxillary antrostomy. This is the posterior wall, and this is the area of the pterygopalatine fossa. We go a little more and drill the pterygoid process in order to reach far lateral, and this is the posterior wall maxillary sinus. We are drilling the orbital process of palatine bone and removing now the posterior portion of the sphenopalatine fossa to reach the far lateral part of the pterygoid recess. You can approach it trans-pterygoid and you can approach it transmaxillary and sparing the tissue. Then you can continue and clean the area. Here, this is the defect, and you can see now we need more drilling of the pterygoid because we need to reach comfortably to the area. This is V2 above and lateral medial to the defect. Then we just did the reconstruction as usually. At the end, I'd like to stress more about the anatomy of the pterygopalatine fossa. It has very important clinical implication. So studying anatomy and dissection is the best way to learn about this area. Thank you very much.
Thank you, Dr. Abdulaziz. Now we'll start the lecture with Dr. Kaziani, please.